Skin, subcutaneous tissue. No? So, you all know this. Nagsukahan na siguro sa histoan, Okay? So, the hair and the skin, largest organ in the body, and it has several appendages. So, first we go to the inflammatory conditions. Skin. Hidradenitis suppurativa. This is usually an inflammatory condition in patients which affects the apocrine glands. So sometimes, maybe some of you have experienced it, no? There is that's the most common area that you can find it. And then, while seeing that, you can see the formation of a sinus tract, or there can be hypertrophic formation. No? So it is usually stage 1, 2, 3. And then, if it is stage 1, there's just pea-sized lump. 2 and 3, there will be a sinus, but with 3, there is already abscess formation. Now, for stage 1 and 2, topical antibiotics would suffice. For stage 2 and 3, advanced stage 2 and 3, excision. Pyoderma gangrenosum. So this is usually associated with hematologic malignancies and inflammatory disorders of GI or rheumatoid arthritis. So you have to treat the underlying condition in order to treat pyoderma gangrenosum. Epidermal necrolysis. So less than 10%, it's Stevens-Johnson syndrome. In between, before it reaches 30%, it becomes SJS10. And then, above that, it's called toxic epidermal necrolysis. So it usually happens 8 weeks after the initiation of a certain drug. So the most common would be anticonvulsants, sulfonamides, allopurinol, oxycam, and ivermectin. So just discontinue the drug that has been used, pause it, and then after, if there is extensive necrotic areas, then you will have to debride. So, rule of thumb, whenever you see something necrotic on the skin, it has to be removed. Okay? So this is not an infection. It is an adverse drug reaction. Injuries. So radiation injury, differentiate UVA from UVB. So for UVA, it just 20 to 30% will just reach the deep dermis. So there is only very superficial penetration. But for UVB, it goes deeper. So UVA causes photooxidation of melanin, and then UVB causes increase in the production of melanin. The different kinds of hyperpigmentation. No? So short-term effects, common you would see would be hyperpigmentation. So napaklay lang ka underneath the sun. So no? Chronic changes, so there can be irregular pigmentation, melasma formation, thinning lentiges. Radiation injury. So this is radiation injury specifically from those receiving radiotherapy. Yeah? So, therapeutic radiation. So you can see eczema, psoriasis, scar, and then keloid formation. Now, the problem also with radiation injury is it also looks like a burn injury. Although in the chronic sense, because you can see in radiation, you subject the patient to a linear accelerator which fires a certain centigrades of radiation to the patient, causing a form of radiation burn. Now, usually the skin of usually irradiated skin is dry. It looks like a scar. So it's itchy, it gets itchy very quickly, it's very dry, it's not moist. So, if you have a patient that comes in and then it's still very superficial, you can treat the patient with just moisturizers. Yeah? That would be enough. But if there would be already areas of necrosis, then you would have to debride. Okay? So trauma. So there will be wounds, no? Lacerations, abrasions, avulsions, punctures. So mostly you need to debride necrotic tissue, if present, irrigate or cleanse the wound to decrease the bacterial load, and then perform wound closure. It could be primary closure by doing suturing, or it may be secondary intention. You just wait for the wound to granulate, or delay primary closure. Now you went through this now with Dr. Sabanat, no? Okay? So for bite wounds, bite wounds are a special kind of wound. No? Now, bites are considered very dirty. No? Who are dog lovers here? Say, hey, you love dogs. Diba? Before you leave the house, mag-lips to lips pa mo sa imong doggy, no? Tell yung bye-bye, bye Fluffy. Then nakamay ka, kasi pinahan. Skila day ka, mag-lecture day ka with Dr. Poson until 7 p.m. So while you're away, imong dog, ato sa silingan, ato sa basurahan, ganana, no? Then, manilingan bitaw, simuton niyang sa sa dog sa Pikas Malay, no? That's how they greet each other. And then when you get home, ipatutbrush na lang sila before niya ipanan. Na may dog toothpaste, di ba? Okay? So, bites are really heavily loaded heavily with bacteria, including human bites, huh? Because if you remember, the oral cavity is the area that is most loaded with bacteria in our bodies. Yeah. So irrigation and debridement is also done. However, in bite wounds, sometimes primary closure is not done. Sometimes you have to delay it because of the chance of infections, which is going to be very high. Huh? So if the animal that bites you is maybe a dog or whatever, ferret, mongoose, another or raccoon, so maybe you might consider rabies post-exposure prophylaxis. Caustic injury. So this was just from the other topic, no? So for acid, coagulative, for alkali, liquefactive necrosis. Okay? So initial treatment is usually copious irrigation with a neutral agent. Most of the time it's just water, no? Hose down the patient. This rope goes down, and then don't use soap. You just use water to dilute the offending agent. And then as far as the scars are concerned, you can treat accordingly. If there are necrotic areas again, what do you do? Debridement. Okay? So another form of injury, special form of injury is extravasation injury. So sometimes patients with IV lines would develop certain edema or swelling around the site that has been punctured by a venoclysis. So it has the same effect or a similar effect as a burn. Siguro, tauran kong IV, then nag-isip ka, nag-swim pa ka kapila, so na-skewer yung kapilang vein. Then, ay mo na shoot. And then, 2 days later, extravasation injury. So the fluid accumulated around the area na hindi arnaan. And then, na ay dissociation between the dermis and epidermis, or even deeper, depending on the punctured area. Huh? So, it might result into something like that, no? An ulceration later on. So, necrotic area, debridement. But, as for the IV line, you have to remove the IV line and then transfer it somewhere else. Maybe sa right, then sa left na po naman. Okay, burns. Okay, we already discussed this. Pressure injury. So, this is common in bedridden patients. Of course, if you can move around, if you can move around the nakay bed sore, what are you doing with your life? No? So anyway, if the pressure usually exceeds 30 millimeters mercury, and the magic number is 6 hours of continuous pressure, then that could result into ischemia of the area. Now, the depth of involvement is how we are going to stage them. Okay? 1 is on the top, 2 is on the dermis, 3 subacute, 4 full thickness. Full thickness. So makikita na have bone. But sometimes you cannot stage the pressure injury initially. And the only way you'll be able to stage it is after debridement. So you will gap and gap and gap, and then, okay na. The tissue is viable, then you stop cutting. Okay? So, it usually involves those areas with bony prominences. So, the sacrum is actually the most common area. It can also be the occipital area, elbows, the heels. So any surface with a body prominence, those will be the areas that are most susceptible to pressure injuries. So, marker of quality of care. So, kung dili mayo gaala ka sa imo, magka-bed-surg ka. So, you have to turn the patient to the sides every 2 hours. So, for surgery, of course, remove necrotic tissue and any fluid accumulations if there are any. So, if there's necrotic bone, we would remove the bone. Skin, remove. Muscle, remove. Anything necrotic should not be in the body. Okay? Now, for closure of the wound, the most common approach is just to wait for it to granulate. However, there are some scenarios wherein it would be better to do primary closure, or maybe put a biological dressing like a skin graft, for example. Okay? Bacterial infections, acne, siguro, tanan, kaagyan. So most common, Staph aureus. It's called an uncomplicated infection if the surface area is less than 75 centimeters squared. So there's typhus, cellulitis, folliculitis, or simple abscesses. It could be complicated if the surface area is more than 75 square centimeters. They could also be necrotizing. Now, the thing here there is associated with comorbidities. So maybe all of you have heard of people with diabetes, and then they get wounds, especially in the lower extremities. They would progress very, very fast. Okay? So, siguro, pag sukahan mo ano pag niyo sa NMMC kay left and right, you can see diabetic foot, diabetic foot, diabetic foot. And once you smell it, you'll never forget it. Actinomycosis, so this is an infection. The problem with actinomycosis is it looks like a malignancy. So, how are you going to know? You're just going to do a punch biopsy or incision biopsy. You don't have to remove the entire lesion. Because if you are going to confirm that it is actinomycosis, then you just treat the patient with antibiotics and it's going to go away. However, if there are necrotic areas, treatment. Yun na siya. HPV. Oh, maybe some of you know. Your dirty fingers have wandered wherever. Although it happens also in people like, let's say, kaya nag-jogging ka, then tusok ka, tunog yung ikuan, or nag-bike ka. It happens. I had a patient before, she was a biker. Then, murag na niyang tail sa basta, ugaw to na kuan surface. Then, she got a subungal wart, which is a wart underneath the nail, the big toe. So those are really hard to remove, no? Because subungal under the toenail is a very, very thin layer of skin, and then it's already the bone. How are you going to remove that? Vitamin chemotherapy. So with warts, no, human papillomavirus, there are many subtypes. They can either be cutaneous or mucosal. These are removed by cauterization, cryosurgery, or laser ablation, or local chemotherapy. So the example I gave you earlier about the biker, no? I had her undergo local chemotherapy. So she was a nurse. She was a nurse, so inject niya yung kaugalingon. So she injected bleomycin on the lesion and underneath the lesion. So that's how she did it. Local chemotherapy. Because HPV can cause acceleration in the squamous cell proliferation. That's why if you inject a chemotherapeutic agent, it halts that increase in the cell division. Kaposi sarcoma. So this is common in AIDS patients. But not all AIDS patients get Kaposi sarcoma. So benign tumors, so maybe some of you have these. There are mga skin tag, lipoma, dermal inclusion cysts, etc., etc. So if you have problems, may mga lesions or what, go to room 236 Polymedic Plaza Monday to Friday, 9 a.m. to 12. Nice student discount. Joke. Basta, these tumors, these benign tumors are usually only treated if they give the patient problems. Like let's say for example, there's a big skin tag under his maxillary area of the patient, and then babae, tag yun, di ba? Disputing, no? Or if there is a epidermal inclusion cyst on the chest of the patient, and then it gets infected every now and then. So, if it is giving the patient problems, then you may remove the tumor. But if not, then pwede naman siya pasagdan. Na may uban ka, di ba? Na ay lantik, anting-anting na nakaw. Na skin tag ni, or skin tag ni. Dili pa hilang doon. Okay, may nakahatag swerte. Okay. Basal cell carcinoma. So, the most, the risk factor would be UV exposure. It's common in sun-exposed areas. Now, the goal usually is to do an excision with a 4 to 10 millimeter margin with most surgery. So, if you see this diagram here, for most surgery, it is a technique wherein we use what we call a frozen section. So, during the surgery, the surgeon will cut the lesion and then send it to the pathologist who will do a frozen section biopsy to identify if the margins are positive or negative for the tumor. If they're positive, the pathologist will tell you in what area then that's where you cut some more. But until negative entire margin, that's when you stop. So this is usually employed in areas wherein cosmetical or functional consequences are going to be catastrophic if you remove a significant amount of tissue. For example, the face. No? Okay. If you have, let's say, squamous cell carcinoma, basal cell carcinoma of the lip, you're not going to remove 3 centimeters right away. You will have to know the extent of the tumor or extent of margin invasion. So once you achieve the R0, which means 0 cross 0 microscopic margins, then that is when you halt the procedure. Then you can do wound closure depending on how big the defect is. It could be primary closure, flap, or graft. Cryosurgery can also be done, no? So cryosurgery will use liquid nitrogen in the area. Laser ablation, similar. Radiation. So same, radiation. If the patients are not good candidates for local excision, radiation is going to be used. Topical imiquimod or 5-fluorouracil. So topical chemotherapeutic agents. Squamous cell carcinoma. So this is the cancer wherein HPV is highly associated with. Okay, one of the risk factors also could be UV exposure, and then there can be low risk or high risk lesions. So low risk would be maybe stage 1, just local invasion, no more spread to the lymph nodes. But when it is high risk, then there's already lymph node spread, maybe bone spread, and then maybe distant metastasis as well. Most surgery can also be done on those sensitive areas, but however, if it's a more advanced disease state, you might have to resort to more radical procedures. Like for example, squamous cell carcinoma of the lip that has already spread to the oral cavity and the gingiva. So you just can't remove the tumor. You will also have to remove a margin. You will also have to remove half of the mandible and the skin here, and do a neck dissection, so which we call a commando operation. Composite mandibulectomy and neck dissection operation. So that's one example. But if it is usually a low risk, then no problem. You can just locally excise the tumor, and then if you identify that the margins are negative, then that's the end of the procedure. Now, for all patients with squamous cell carcinoma, they would require chemo and radiation. Chemo and radiation, adjuvant. Okay? Although sometimes, in some circumstances, pwede na you just observe. Melanoma. So, you could diagnose melanoma by the ABCD, right? Symmetry, border irregularity, color, and diameter. So, melanomas can either be cutaneous or mucosal. So, they're also associated with UV exposure. Now, types are superficial spreading, nodular, and lymphopenic. So, when you biopsy the lesion, if the lesion is large, then maybe you can do a punch biopsy of part of the lesion. So not removing the entire lesion to confirm it. But if the lesion is small, then of course you have to remove the entire lesion. Maybe if it's just 5 millimeters, then you remove the entire lesion. Okay? Afterwards, you will have to do a metastatic workup. If you remove the entire lesion, and then you determine the thickness, which is the most important prognostic factor, then you can know how much to cut. No? So the breast load thickness is going to tell you 5-year survival and depending on the depth of invasion. So breast lobe thickness is how deep the tumor is in the skin. So if the tumor, part of the tumor protrudes above the skin, that is not included in the breast lobe thickness. It's only the part of the tumor that is underneath the skin. Sentinel lymph node biopsy is a technique wherein we are going to identify the sentinel lymph node in patients with melanomas or lower extremity malignancies to check if they have already invaded the lymph nodes. Usually the lymph nodes to be dissected are at the inguinal areas. So a blue dye with a radioactive agent is going to be inserted on the tumor, and then you're going to check with a Geiger counter the area which lights up, no? And then if you see a blue lymph node that is reactive with the Geiger counter, then that's what you can submit to the pathologist for an examination, a frozen section. The pathologist will determine if there are malignant cells present in that lymph node. If there are, you proceed with a formal inguinal lymph node dissection. If they are negative, tapos na. Similar with breast, no? Later na ng breast. So, if you have a patient with clinically enlarged inguinal lymph nodes, no need to do a cervical, an inguinal sentinel lymph node biopsy. Okay? And ano mo kinakita na enlarged lymph nodes? So you do a formal inguinal lymph node dissection. So for a melanoma in situ, 5 to 1 centimeter margin, tumor of less than 1 millimeter, 1 to 1, 1 to 2, be 1 to 2, and then greater than 2 millimeter thickness will be 2 cm. So just remember 1 to 2, if wala siya, no? There are some patients who might not be able to tolerate systemic chemotherapy with melanomas after excision. So you can resort to isolated lymph perfusion or isolated lymph infusion. So what is done here is the lymph is a vascular catheter is inserted to the artery and the vein of the lymph in concern. Chemotherapeutic drug is then instilled to that extremity, and then a tourniquet is applied to cut off the circulation. Okay? For isolated lymph perfusion, the patient is connected to a perfusor or a heart-lung machine, so it can stay there for a longer time. But for ILI, no more. So you can only do it for a short period of time, which would be less than 6 hours. Okay? Okay, so anyway, there are other malignancies: Merkel cell, Kaposi sarcoma, fibrosarcoma protuberans, MFH, angiosarcoma, and extramammary disease. So most of these conditions will be treated by excision and staging, and afterwards there could be adjuvant therapies. But with Kaposi sarcoma, it's usually you treat the underlying condition. But if it causes problems, because it is a vascular tumor in origin, then that is when you can perform surgery, maybe a wide excision. Maybe there could be bleeding, significant bleeding in that area, not being treated well by maybe give the patient hemostat, tranexamic acid, like Yapun, do local pressure control, then maybe you can resect. Okay? So any questions? Basahin na ulit. Yeah? So, burns are just basically identifying the type of burn, resuscitating the patient, identifying if there are any other injuries, smoke inhalation injury, or if it's electrocution injury, you could evaluate further. If it's chemical burns, then the exposure, no? And then you have to irrigate the patient. Wound coverage, management of compartment syndrome, healthcare-related complications like mechanical ventilator-associated pneumonia, compartment syndrome, catheter-related infections, and then the long-term, complications that can happen long-term like contractures. Okay, so that's with burns. With skin and soft tissue, so basta, necrotic, pantang. Yeah? Tumor, pantang, except itong actinomycosis. Yeah? Biopsy, kung actinomycosis, treat with penicillin. If it's a malignancy, then that's a different story. So with the malignancies, excise with a margin, and then chemotherapy or radiotherapy, depending on what kind of malignancy. For the benign tumors, remove only if it causes problems. Yeah? Okay, so muna mga few tips that I can give you. Okay, next will be your long quiz. Questions?